Very good evening, everyone. It is my pleasure to welcome you all today's session, Hidden in the Heart, exploring the genetic basis of cardiovascular disorder. Cardiovascular disorders are often viewed through the lens of lifestyle and environmental factors, but an increasing number of heart conditions has a significant genetic component. Understanding these inherited disorders is transforming the way we diagnose, manage, and counsel affected individuals and their families. To guide us through this fascinating and rapidly evolving field, we are honored to have us with today Dr. Kshitija Patil ma'am, a distinguished clinical geneticist from Apollo Hospital, Navi, Mumbai. She holds a MBBS, MD and DM in medical genetics from AIMS, New Delhi. Ma'am has extensive expertise in clinical genetics and has been actively involved in the diagnosis and management of various genetic conditions. Her work has greatly contributed to the improving our understanding of inherited disorders and their clinical implications. In today's talk, ma'am will help us uncover the genetic mechanism underlying cardiovascular disorders, discuss their clinical significance, and highlight the importance of early diagnosis and multidisciplinary care. We are truly delighted to have you with us, ma'am, and we look forward to learn from you and your valuable insights. Without further delay, I invite Dr. Kshitija Patil, ma'am, to begin her presentation. Now, over to you, ma'am.
Thank you so much, Nadir, for that kind introduction. And I think in your introduction itself, you have very nicely summarized what I want to say and the crux of today's presentation. So I have, titled it Hidden in the Heart to make it sound very attractive. Basically, we are going to discuss the genetic causes of cardiovascular disorders. Okay, so commonly when we think of cardiovascular disorders, as you rightly said, we mostly think of the acquired disorders, lifestyle related, smoking or alcohol risk related, age related things. But there are a substantial portion of these fatal events, cardiac events, that are actually driven by genetic mutations. And they could be cases of sudden cardiac deaths or, thoracic aortic aneurysms or some coronary artery disease. So we need to basically have an index of suspicion in such cases, and we will discuss. So basically, firstly, just to give you an idea of what is the prevalence of these disorders. So I have taken these figures from published literature. So inherited cardiac conditions contribute to about 30% of sudden cardiac deaths in young individuals. So if you see, common conditions would include familial hypercholesterolemias, which is in fact an often missed and underdiagnosed condition. Prevalence is as high as 1 in 250, and even ICMR studies show that in India also the prevalence matches 1 in 250. Likewise, for cardiomyopathies, dilated cardiomyopathies, this 2018 study puts it at 1 in 250. I would say dilated as well as hypertrophic are falling somewhere around 1 in 500. Likewise, arrhythmogenic disorders in 1 in 1000 to 1 in 5000. Long QT syndrome, particularly 1 in 2000. Marfan syndrome, 1 in 5000. So, and when you look at the sheer population of our country, this is not very rare. So when they say, like, collectively, the rare disorders are quite substantial. So what would certain genetic cardiac conditions be? So they can be aortopathies, which are like part of connective tissue disorders like Marfan syndrome or Loeys syndrome. They could be metabolic conditions like familial hypercholesterolemia leading to disease, or cardiomyopathies like structural muscle issues, or they could be channelopathies, conduction issues like long QT syndrome, Brugada syndrome, or they could be simply problem with the structure of the heart, a congenital heart disease. They would present relatively early, maybe like in infancy. I'm just going to begin like age-wise. Like let's start with the youngest patients. So all these cases that I'm discussing are drawn from published case reports. Okay, so this is one condition where you have a newborn coming with feeding difficulties, bluish discoloration. There could be a cardiac murmur on auscultation. So in echocardiography, there was a truncus arteriosus detected. Now, whenever you have conotruncal anomalies, okay, like tetralogy of Fallot, truncus arteriosus, or any such conditions, we generally want to rule out genetic conditions, especially the 22q11.2 microdeletion syndrome. Okay, so that is the Dye-George syndrome, as we call it, or velocardiofacial syndrome. Now, cardiac conditions, these cardiac congenital heart diseases, many of the times could be idiopathic, sporadic, isolated finding, but it is important not to miss if it is a part of syndrome. And why we will see. So as I was saying, congenital heart disease is one of the commonest congenital anomalies with a prevalence of 8 per 1,000 live births. But about 20 to 30% of them will have an underlying genetic cause. So especially, as I said, when you have conotruncal anomalies or certain other signs present in the patient where you suspect a abnormality, you want to dig deeper. And why? Because they could have broader syndromic morbidities. Like in case of 22q11.2 for Dye-George, we know they are prone to hypocalcemia. They can have airway concerns. A very important issue here is the immune dysfunction. And also they can have feeding difficulties and many more such presenting points. So whenever these patients have to undergo any management, any surgical intervention, we need to be mindful of these other comorbidities and manage them well. So that is the reason. So you know, the actual cardiac disorder would be like, it's like a saying that it is a tip of the iceberg, that you are just seeing the cardiac condition, but underlying there could be so many other comorbidities that you do not want to miss. And the common so when would you suspect? As I said, about 60-70% could be just idiopathic isolated cardiac conditions. But especially when you have conotruncal abnormalities or multiple anomalies. Additionally, if there is some dysmorphism, like very typically we say a pear-shaped nose or some other kind of dysmorphism, developmental concerns associated, so multi-system involvement, or specifically if there is a family history or a previous affected child, then we suspect any genetic condition, syndromic condition. So common syndromes, I would say, are 22q11.2 as we discussed, where you have conotruncal defects, or it could be the rasopathy spectrum like Noonan syndrome, where you have typically a pulmonary stenosis and hypertrophic cardiomyopathy. These are the common presentations with Noonan. CHARGE syndrome can present with conotruncal defects again, or AVSD, or aortic arch anomalies. Heterotaxy syndromes, they present with complex cardiac heart disease, complex congenital heart disease with laterality defects, and also they could have AVSD or some anomalous venous return conditions. Okay, so in these cases, we can expect that there could be associated comorbidities. Getting a proper diagnosis, it is just not for labeling the patient, but also to be mindful of the other comorbidities that we can expect, diagnose them, treat them, and put the patient on appropriate surveillance. Now let us come to another condition related to the cardiovascular system. So here I am discussing a case of athlete who suddenly collapsed. So there was this 17-year-old athlete who has collapsed in a football match. And in the family history, there was a significant history of an uncle who had died at the age of 30. So early death, early sudden death. Now this ECG image here, it is showing pathological Q waves and repolarization abnormalities which are suggestive of hypertrophic cardiomyopathy. And as an echo done subsequently confirmed that there was asymmetric septal hypertrophy. Okay, so now hypertrophic cardiomyopathy, it is again a common inherited disorder with prevalence of 1 in 500 individuals. Now, and most commonly, these dilated or hypertrophy, the cardiomyopathies, they follow an autosomal dominant inheritance pattern. It could have occurred de novo, like newly in an individual, or it could be passing down in an autosomal dominant fashion. Okay, so common genes involved with HOCM are MYH7, MYBPC3, TNNT2. Okay, so they are basically encoding the sarcomeric proteins which are responsible for myocardial contraction. So if there is any variation, coding change in these genes, it leads to myocardial hypertrophy, myocyte disarray, and fibrosis. So basically, if we have a diagnosis, we can help in risk stratification, early surveillance, preventive care. We can diagnose other family members and put them on surveillance accordingly. Now let us look at another case. We just discussed a case of hypertrophic cardiomyopathy. Now this was a similar case. This is another case report. I have referenced it here. So this was a case where hypertrophic cardiomyopathy was diagnosed. Patient underwent evaluation, underwent surgery for septal myomectomy, and then when histopathology was sent on that myomectomy tissue, they found that it was actually a case of Fabry disease. So Fabry disease is a known phenocopy. So what is the meaning of phenocopy? It is something which is mimicking the disorder. So there are certain conditions which will appear like hypertrophic cardiomyopathy, but it is just like a part of manifestation of that disorder. It is very important to diagnose because it changes the therapy, surveillance, family counseling. Okay, so because here just the mere myomectomy is not going to help the disorder. The patient requires enzyme replacement therapy. Okay, so the entire family screening, management, everything will differ. So the common genes as we discussed for hypertrophic cardiomyopathy are MYH7, MYBP3, TNNT2, TNNI3. Likewise for dilated, they are TTN, LMNA, DSP, FLNC or PKP2. But we should also be aware of the phenocopies like Fabry disease, amyloidosis, Danon disease, or mitochondrial disorders or such conditions. Okay, so it is important because their management may involve enzyme replacement or some metabolic therapies or some different surveillance strategies. Okay. Okay, so now let us look at another situation where you have sudden death during sleep. So this is a case report where there is a 23-year-old man who was found dead in his sleep. So autopsy revealed a structurally normal heart, so no cardiomyopathy, right? So in this case, they tested the extended family. Okay, so where siblings ECG showed ST elevation in the V1, V3 regions and overall pattern which was suggestive of Brugada syndrome. Now, Brugada syndrome is a channelopathy caused because of variation in SCN5A gene. So basically, it predisposes the patient to ventricular arrhythmias, and structurally the heart is appearing normal. Okay, so likewise, long QT syndrome is another channelopathy. So these are cardiac channelopathies, okay, where any variations in genes like KCNQ1, KCNH2. Okay, so these variations cause problems in conduction and they affect the ion channels of the heart and cause arrhythmias. So, in these cases, many times a single resting ECG may not give you a diagnosis. You may, depending on what syndrome you are suspecting, the family history, etc., they may require either serial ECGs or exercise testing, any ambulatory rhythm monitoring like a Holter monitoring for reaching a diagnosis. So, basically, finding out which gene it is again not just for labeling, but it can help us to prognosticate the disease. Like say it is a PKP2, then you know that you need to monitor for progressive ventricular dysfunction or arrhythmia risk. KCNQ1, there are treatment implications. You know that this patient will respond better to beta blockers. So this helps the treating physician, the cardiologist in this case, to make therapeutic decisions for the patient. Okay. So Okay, so now we saw congenital heart diseases, we saw cardiomyopathies, we saw their mimics, we saw conduction disorders, channelopathies. Now this is another patient who is tall stature presenting with chest pain. Now you are familiar with Marfan syndrome. So this patient. He had long limbs, hypermobility, pectus deformity, and on 2D echo there was aortic root dilatation. Okay, so inherited aortopathy, it usually usually in such cases you will suspect a connective tissue disorder. Now just connective tissue disorder is not enough. We need to know what exactly is the diagnosis, because it has implications for therapeutics. Okay, so like say if there is an aortic root dilatation, if it is case of Marfan syndrome, the threshold for surgery is different compared to Loidids, where the threshold is much lower. So this is a case where you have a 3-year-old child presenting with marked aortic root dilatation and ascending aorta dilatation and severe aortic regurgitation. But here, intraoperatively, the valve anatomy was quite preserved. So they did a David procedure, which is basically like a valve sparing root replacement rather than replacing the valve. So this is basically the guideline for, because there are case reports where better results have been achieved by doing valve sparing surgeries in case of Loidids patients. So it was important to know the diagnosis for the for deciding the course of management. So connective tissue disorders, they could be Marfan syndrome related to the FBN1 gene variation, or Loidids, which has quite a few genes, TGFBR1, 2, or SMAD2, 3, TGFB2 or 3. Okay, so or it could be other connective tissue disorders like Ehlers-Danlos or just familiar thoracic aortic aneurysm. Okay, so they have different surgical thresholds. Okay, so some of them, they might dissect even at smaller diameters. And again, tissue fragility will vary with the type of connective tissue disorder. And long-term follow-up is going to be required for any of these conditions. Okay, so it is going to, so having a diagnosis will definitely help in the surveillance and management. Okay, as I said, so if you see, surgical threshold for a normal degenerative aneurysm is much higher compared to that of a syndromic case, especially Loidids compared to Marfan's. Okay, so definitely the genetic diagnosis changes the management. Now let us look at another type of case. Here you have a patient with a heart attack at an early age. Okay, now if you look at the patient's lipid profile, you see a very high level of LDL. Okay, and also on careful examination, there are tendon xanthomas. Okay, patient's father has also passed away at an early age. So in such cases, as I discussed in the beginning of the talk, these familial hypercholesterolemias, they are actually very common and quite prevalent, but are underdiagnosed. Okay, they are the prevalence is as much as 1 in 250 individuals. The common gene involved is LDLR, but other genes also like APOB or PCSK9 um, uh, may have a variation. So how does knowing that, okay, so if there is a, um, CAD, you're going to manage it anyways. Okay, so you may do a percutaneous coronary intervention. But if you know that this is a case of familial hypercholesterolemia, maybe a gene mutation, variation as we call it now, in say an LDLR or a PCSK9 gene, then you know that a CABG may be preferred over PCI for a severe early onset diffuse disorder. Okay, so this is a so basically it changes the management line of management in these cases, right? And also we know that if it is a hereditary condition, familial condition, the person is prone to it, it may require multiple arterial grafts, and the lipid management will have to be aggressive with lipid lowering drugs. Okay, so definitely management will vary depending on the diagnosis. So whether or not it is familial, whether it is familial or not is going to change your the aggression with which you are going to manage the disease. Okay, this is another condition. This is relatively rare among rare, but if you see, so medial arterial calcification is a condition. So it would present just like narrowing of the arteries. But if you see the normal cases where you have atherosclerosis, this plaque forms in the beneath the tunica intima. Okay, the inner layer of the arteries. Whereas the medial artery calcification, it basically causes calcium deposits in the this is because of genetic variation, which causes calcium deposits in the muscular layer, that is the medial layer of the arteries. Okay. So in this case, what happens is the walls become very rigid and stiff, and they are not like these normal arteries. Okay, so in them, usually the interventions become very difficult because graft anastomosis is difficult. There are limited conduit selections, and there is increased risk of graft failure. So this advanced knowledge, if present, if available to the treating surgeon in advance, can be of value. So the normal mutation, the common mutations here are ENPP1 gene related deficiency in infant onset, the early onset, infantile onset medial artery calcification, and NT5E are related to the adult onset calcification. Okay, so now this is where we saw a lot of cardiac conditions, but going beyond that, in general, the cardiovascular management. So this is one case where a 58-year-old was undergoing a surgery for a cardiac cause. He had an aortic dissection and was undergoing a surgery, but suddenly after giving anesthetics, he developed severe hypermetabolic crisis. There was basically rapidly rising EtCO2 and muscle rigidity, tachycardia, hyperthermia, hyperkalemia, rhabdomyolysis. So basically, he was in a hypermetabolic crisis. That is, he had malignant hyperthermia. Okay, so now this is caused because of mutations, coding changes, variations in the RYR1 gene, and sometimes in the CACNA1S gene that causes susceptibility to malignant hyperthermia in reaction to in response to certain anesthetic drugs. Okay, so now this case was managed with deep hypothermia, cardiopulmonary bypass, till dantrolene becomes available, because dantrolene is the drug of choice for this, but procurement is sometimes a bit problematic. So so now that this diagnosis was made, now they knew that okay, this patient is at risk, and in future they can manage accordingly and avoid the triggers like those anesthetic agents. Also, pharmacogenomics is very well known and has been used in cardiovascular disorders since a long time. We know regarding certain polymorphisms in the VKORC1 gene or CYP2C9 gene, which can alter the dose of warfarin. Okay, so certain polymorphisms require lower dose of warfarin because they are slow metabolizers of warfarin. Okay, likewise, clopidogrel non-response, certain loss of function mutations in the CYP2C19 gene. Okay, so they will not be responding to clopidogrel like normal individuals. Okay, so likewise, there are these implications in pharmacogenomics as well. Okay, so we saw different conditions and leading to different managements, right from cyanotic newborns where you had a truncus arteriosus because it was a conotruncal anomaly, you suspected genetic disorder, you do a testing, make a diagnosis, help in multi-system surveillance, okay, and guide the management accordingly. If you have a collapsed athlete, okay, it could still be related to genetics because of sarcomeric changes. We studied about hypertrophic cardiomyopathy, and we can help with restratification, cascade screening. Likewise, any cardiac channelopathies like Brugada. We saw connective tissue disorders with aortic root dilatation and how different diagnoses will have different management, different connective tissues will have different interventions. Okay, and also the familial hypercholesterolemias and other implications like your pharmacogenomics as well. Okay, so what is the most important part here is like, people would say many times, okay, aortic aneurysm, suddenly, I mean, we could not help that patient. But the first indication of inherited disorder, if you have a pedigree in your history taking, if you take a proper pedigree, you can help in diagnosing other patients who are in the family who are still not manifested. You can help them by putting them on surveillance or proactively looking for any conditions and intervening in time. Okay, so basically the family members who have tested positive, they can undergo surveillance, they can have preventive care, and it will reduce mortality across that entire lineage, especially because, as I said, a lot of these cardiac disorders are autosomal dominant inheritance. Okay, so rather than reacting to emergencies, we can move towards proactive prevention. So especially things which should draw our attention would be any thoracic aortic aneurysms, any hypertrophic cardiomyopathies, many of the dilated cardiomyopathies, syndromic congenital heart diseases, okay, because we can always help in doing cascade screening, other than first managing this patient, doing a multidisciplinary management of this patient, uh, giving any elective prophylactic treatment, or guiding the surgical intervention based on the diagnosis. Okay, and also it is crucial for reproductive and long-term family planning depending on risk of recurrence. As you know, we now have preventive measures also. We can do prenatal screening. There is also pre-implantation genetic testing available for any known familial conditions. I want to also say a few words about polygenic risk scores. So, as we know, all of these conditions that we discussed, most of them were monogenic conditions, which are definitely high impact mutations, where that it follows a certain inheritance pattern, and you can associate it with certain disorder. But nowadays we also have a lot of these polygenic risk score based testing which is available. Many of these tests are available over the counter. So people who have these high polygenic risk scores, in certain conditions, they may have as much as threefold risk compared to general population. And accordingly, basically those findings can help, can basically be integrated into preventive cardiology, basically. So the conditions where it has, so AHA had come up with a statement regarding the polygenic risk scores, where they have kind of advocated its use for coronary artery disease and also atrial fibrillation to some extent, where so they say that it can predict and can have implications in surveillance and management. And just to touch upon the newer things that are happening in the cardiovascular genetics area, so there are certain gene editing therapies that are being worked upon, CRISPR-Cas based gene therapies, where they are targeting the TTR gene for transthyretin amyloidosis. And there has been some, though these are still not in therapeutics, but a lot of work is going on in this area. We may soon see some gene therapies coming in cardiovascular genetics. Likewise, so these are, CRISPR would be like a DNA-based gene therapy. There are certain RNA-based therapies also, like RNA silencing therapies, which are being worked upon, but they are still like a work in progress, not available for clinical practice yet. So after discussing all of this, we must have realized that it is not just about only imaging, or so all these things, like, or only genetic testing, all these things need to be integrated. So first most important base would be formed by the rigorous clinical information that you get, the family history, patient's examination, all the signs and symptoms, then imaging, your echos, any CTPAs, all that additional imaging information, and then the genomics. And all of this integrated together can help us in practicing precision cardiology, where you can give individualized risk predictions, genotype guided therapies, improving disease classifications, etc. Okay, and always most of these, though, main treating doctors would be the cardiologist, cardiac surgeons, but it is usually a multidisciplinary management, especially when genetics is involved, because interpretation of VUS is a challenge, managing prognosticating patients with incomplete penetrance. This becomes a problem. Surveillance, cascade screening. So it's usually a multidisciplinary collaborative effort when it comes to genetic cardiology. And with a collaborative effort, we can identify the exact molecular route and get any systemic risks, and help in proper risk stratification, help with timely interventions, guiding of the proper, say, pharmacotherapy, choice of medication, time of surgery, choice of surgery, and also cascade screening and identifying other at-risk members to put them on surveillance. So I want to end by saying the mutations may be hidden in the heart, but modern genetics can uncover it before disaster strikes. Thank you. I will be happy to take any questions if there are. I think I will stop sharing my screen.
Thank you so much, ma'am. It was very enlightening and very highlighted topic, and you have completed very nicely. You have covered almost everything with respect to cardiovascular conditions and the genetic disorders. We are open to questions now, and I would like everyone to ask few questions if you have. Before that, I will ask one question. So, what are the major challenges in counseling children and adolescents who are at risk for inherited cardiovascular disorder?
Right. So usually, like I'm sure, like how you also may have come across these cases. I think what happens is when it comes to a genetic diagnosis, I think it becomes like a family diagnosis, and there is a lot of stigma, or sometimes in case of parents, there is a lot of guilt, related to it. They feel like they have passed on something or some such thing. So I think it is a very nuanced area where we need to explain, and especially when we talk of genetic disorders, it is going to be something which is a lifelong long-term management and surveillance requirement. So and the initial news may come as a what do you say, like a shock to the parents, but we need to explain it properly, and how, and very important in their case is the initial year, because it is the time, the pediatric age group is the age of growth and development. So they need to get the proper management at that time for the basic condition, for all the associated comorbidities, and with that to help with the growth and development, and then to transition them to adult care, to the adult medical care. So I think it is much more challenging in the pediatric age group compared to the adults.
Oh, definitely, ma'am. It is very challenging when it comes to pediatric cases. Related to same only, ma'am, how we need to approach reproductive counseling for couples with a known pathogenic variants, especially associated with cardiomyopathy or channelopathies.
Right. So as I said, many of these are autosomal dominant. Some conditions could be autosomal recessive, but a lot of them are autosomal dominant. So if we know that, so first thing would be, if we identify that in a patient, whether, if it is identified in a child, you want to find out whether the parents are actually carriers. If it is de novo in the child, then the risk of recurrence would be low. But even if it is low, we say there is a less than 1% chance, but that 1% is there because of gonadal mosaicism. So invariably, we offer a prenatal testing. Prenatal testing should always be targeted, because mostly in the imaging, except for congenital heart diseases, you can find it in the imaging. But otherwise, other than structural, like these conduction related issues, you won't get that information in prenatal time if you don't do an invasive testing and test the genes. So definitely, and for patients who are themselves affected, then for their reproductive also, what we can do is offer a prenatal testing. Now, it leads to certain ethical issues, especially for late presenting disorders when for doing prenatal, because usually prenatal testing is offered only for disorders which are difficult to manage, presenting early. So for late onset, I mean, maybe pre-implantation genetic testing becomes a good. I mean, pre-implantation this pre-implantation genetic testing can be for any any condition for prenatal this thing. So what we can do is uh, beforehand you go via IVF beforehand, prepare like whatever embryos, get them tested, and the ones which are not carrying the mutations can be used for implantation via IVF. So I think that becomes
Pre-implantation genetic testing would be the one of the best options. Uh, Same what you have covered a little bit about the ethical issues. So same with the ethical issues. How it will be challenging for the ethical? What are the ethical issues with respect to people to be tested for predictive testing for the asymptomatic people? So what are the ethical challenges do like families or we as a healthcare professionals will face?
Right. So I think in this condition, in cardiac conditions where there are a lot of surveillance implications, there are management implications. So definitely in that case, we need to test because especially like say cardiac conduction disorders, they can present at any age. They can present early as well. So definitely if some such thing is found, then cascade screening is a viable option and should be offered because it would have implications for it. So usually for disorders where there isn't much that you can do or there is no surveillance or no intervention, then usually it becomes questionable. But I think in most of the cardiac conditions, because they have implications for surveillance and management, definitely cascade screening has to be done and testing for yes.
Thank you so much, ma'am. We don't have any questions from the audience, so we will end the session. As we have come to the end of the session, I would like to express our gratitude from ORDI to you, ma'am, for sharing knowledge and experience with us. And thank you all the participants for your active presence and engagement. We hope this session has enhanced our understanding of the genetic basis of cardiovascular disorders and inspired us further interest in this important area of medicine. Least but not the least, thank you ORDI for such an organizing such a wonderful education. Thank you so much. Have a wonderful day.
Thanks a lot, Nadir, and thanks. I thank the ORDI platform for this opportunity. It is always a pleasure associating with ORDI. I think they are doing great work in the area of rare diseases.
Definitely, ma'am.
All right.
Okay. Thank you so much, ma'am.